Okay.
All right, you should see Osirix.
Right.
So this is a nice case I came across last week or so. This patient, this was just post right heart catheterization, looking for a complication, specifically looking for a pneumothorax, and which I've never seen after right heart cath, so I don't know why we do them, but they do them. And one thing that had caught my eye was, and I'll make it bigger, you can see this patient has a cardiac pacer in place, and there's a right atrial appendage and a right ventricular lead, but then there's this little guy here, which looks kind of funny. This looks like one of those transvenous leads they use for resynchronization therapy, typically goes to the coronary sinus. Um, and luckily, we had an old radiograph for comparison, your best friend. And you can see here in this case that the this lead, did I grab the wrong one? I think I may have grabbed the wrong one. Well, anyway, it was in the left ventricle, in going through the coronary sinus into the inferior interventricular vein. So this had somehow dislodged. It's unclear whether it happened during the right heart catheterization or not. I looked at some of their images and it looked like it was already there. So it may have flipped out on its own, or when they were getting access, they snagged it with a wire or something and pulled it back. But anytime there's instrumentation, central line placement, catheterizations, you always have to make sure that these haven't migrated. Of course, they can migrate on their own. I know Howard's shown a couple of cases where the right atrial appendage lead has flipped down. And usually that happens earlier on after placement just because it hasn't scarred in, but important to do that. I'll find the other radiograph, but it showed it in the usual place down here where we'd expect to see it. So that's just a quick one.
I think that radiograph actually does show it in the
Did
normal
I
place.
can't, my laptop screen is so small.
Yeah, it's there.
All right, let me make it bigger. All right, well, I'll take your word for it. I thought
I could see it. Yeah.
this is an interesting case. So this guy, he's middle-aged, presented pretty sick looking, and on his chest CT, he just has some enlarged lymph nodes in his mediastinum, and then he's got this nodule here in his middle lobe, or sorry, his upper lobe, and you can see there's some perilymphatic nodules around it along the fissure and adjacent to it. And that's about it. There's nothing else on his scan. And he comes with a history of chronic non-tuberculous mycobacterial infection. And what's interesting is he had a PET CT because they were finding it in a lot of different places. And you'll see there's diffuse uptake, not in just the lymph nodes, but also in his bones. And there's no destructive lesions. So it's actually all, and you can see it's quite intense in the lungs. And I can't remember the time frame between the two, but so he has had a bone marrow biopsy, and he does have MAC growing in his bone marrow. And you can see there's a bunch of abdominal disease as well. And they thought he had a mutation that makes people susceptible to mycobacterial infection, but he doesn't. But what they did find, and I'll show you, here's the MIP just to show how extensive his disease is that he has autoantibodies to interferon gamma, which I'd never heard of that. But it does predispose people to mycobacterial infection. So he's got diffuse disseminated MAC. So what we're seeing on the chest CT, all this lymph nodes, is all just MAC. We've seen cases in HIV where they would get big lymph nodes. We've seen the classical sort of lung findings, but this is all marrow disease that you can't see on CT. So there are two conditions. Apparently, one, there's a genetic predisposition, probably some sort of immunodeficiency, and then this autoantibodies to interferon gamma that makes you susceptible to certain organisms, particularly mycobacteria. So they have to treat him with heavy-duty mycobacterial drugs, and of course it's hard to clear and at risk for relapse. But I've never seen this or heard of this before, so I don't know, David, if you've ever come across this entity or seen other cases of disseminated MAC. You probably saw it during the sort of the HIV/AIDS epidemic in the 90s and late 80s.
I've never seen this before. That's way cool.
Yeah, The imaging, well, yeah, in and of itself is not interesting, but when you look at the PET and you just see how much just diffuse uptake there's, this is all abnormal bone uptake, and then you can see all these lymph nodes and then just areas in the abdomen. All right, and then my last case is kind of a cool case that I know you're going to like. So this was a consult from our pulmonologist for chronic cough. And so this is outside CT, and you can see, first I'll point out that the trachea has sort of this, like this corrugated look to it. It's not huge, but it doesn't look like a nice round trachea. And then it's very obvious there's these lucent spaces in the lungs, and most of them, if you scroll through them, see that they're branching. So these are all dilated airways. And you'll notice the central airways are a little abnormal, but they're not as big. And then if you go way out to the periphery, most of the airways are normal again. So I think this is along the Williams-Campbell spectrum, whatever we want to call it. It's probably related to a lot of this congenital or acquired stuff. But notice the corrugated appearance of the airways. That's commonly seen with both Meunier-Kuhn and Williams-Campbell, but it sort of has the right distribution of the abnormal bronchi. They don't have thick walls. There's some inflammatory nodules. I don't have expiratory on this CT. However, he had another CT done elsewhere earlier where he can't hold his breath, which gives us free expiratory images. And you can see there's definitely hypercollapsibility of the lung, probably a mix of some mild malacia, but more likely redundancy or weakness of the posterior membrane. So we see a sort of an excessive dynamic airway collapse, which goes along with these sort of chronic central airways abnormalities. He also has esophageal dysmotility, so it's hard to know if he's aspirating, if that's playing a role, or if it's just making things worse. You can see secretions pooling, a lot of dependent inflammatory stuff. So a nice case of what of bronchiectasis that would fit the bill for Williams-Campbell syndrome based on the sort of 4th through 6th order airways, but also associated with some Meunier-Kuhn-like physiology. Even though it's not a huge trachea, I think it has that corrugated look, and it has the hypercollapsibility. Here it is on the sagittal, and you can just see sort of the accentuated rings.
Jeff, how old is this person?
This person is 70.
Wow, okay.
So if you look in the books and the literature, they talk about most cases of Williams-Campbell presenting in the first year of life. I don't believe it. And it's probably not one condition. It's probably the end point. Just like Meunier-Kuhn, it's probably the end point of multiple conditions, whether it's various weaknesses in elastic tissue, cartilage, muscle in the airways. And he just presented late. But as far as I know, he doesn't have mycobacterial infection, and there's not a lot of thickening that you often see with chronic infection or even cystic fibrosis. It's these very thin airways, and I think they're just very weakened from whatever abnormality he has.
I think it's a structural problem. So yeah, I mean, it's a really nice example of dilation without thickening.
Right.
Really important to report those separately. You know, dilation with or without thickening, thickening with or without dilation.
Right. Yeah, but a lot of the textbooks talk about these as being so-called congenital, and it's more that you're born with the structural defect and then what happens depends on a lot of factors, but it sort of leads to a common endpoint. Why it spares the other airways, I don't know. It must be differences in structure, but they often, in my experience, the ones that with the so-called Williams-Campbell often have Meunier-Kuhn features and vice versa, depending, because it's sort of all the same tissues. All right, well, those are my 3 cases. Let's see,
I have one if you want to.
Yeah, I need to make a presenter. There we go.
Let me rearrange my screen here for 1 second before you switch control to me. Okay.
Okay.
Okay. Can you try again?
Sure. Let me take it back and then give it back to you. All right. Try now.
Okay. So I'd like to show just this one case here This is a person who is working at the Hanford Nuclear Reservation cleanup. So this is the site of plutonium production starting in World War II with the Manhattan Project, and then on, I think, into the 70s or even 80s for the nuclear weapons program. And this person began work there in about 2002, I think. And shortly after this person started working there with exposure to beryllium, this person developed lymphadenopathy. Now I'm going to show you an exam here. This is from, I think this is from 2013, but I have earlier radiographs that go back to 2002. So for more than 20 years, this person has had this lymphadenopathy. Here you see particularly this right paratracheal, sorry, this right hilar lymphadenopathy. And it's been fairly stable. So here's our current radiograph is, I think, yesterday, and we still have that lymphadenopathy there. So this is an extraordinary long period of time with lymphadenopathy. And here's what we have: two CT scans from the mid-teens, and they both show this about the same amount of lymphadenopathy. So modest mediastinal lymphadenopathy and hilar lymphadenopathy. So it's been there for a long time. This person is exposed to beryllium, which was used as a moderator. And in the cleanup, these people are dismantling the buildings and trying to clean things up and, take all of this contaminated debris and make it safe for humans. So this person is exposed to beryllium, and there's beryllium surveillance program. The interesting thing is that this sort of pattern is very typical of what I've seen in these Hanford cleanup workers, and that is a chronic hilar lymphadenopathy. It looks just like sarcoid. They rarely have lung disease, and CT on this person does not show any lung disease, just the mediastinal and hilar lymphadenopathy. And yet these people only variably test positive for beryllium sensitization. So, and the National Jewish is brought in on many of these cases to do the sensitization testing, but about half of them don't have positive sensitization tests, but they have the exposure. And I think, the sensitization tests are only about 75 or 80% sensitive. My thought then is, having seen about 20 of these people with this pattern of lymphadenopathy that looks like sarcoid but doesn't go away, sarcoid would not be stable for 20 years, is that this is probably chronic beryllium disease. And probably the people that have lymphadenopathy but don't have any lung findings even on a CT scan may be the people who are most likely to have negative sensitization tests. Now, this is just my private hypothesis in all of this business, but I've seen this pattern so consistently. If this evolved faster, I would think, well, it's just a case of sarcoid. But these are people who are exposed to beryllium. They're often in a surveillance program. They have this chronic lymphadenopathy, and yet only about half of them, in my experience, will have positive sensitization tests. So I would like to propose this as chronic lymphadenopathy as probable beryllium disease. And maybe if you don't have the lung disease that's detectable on CT, you're more likely to be in that negative sensitization testing group. So,
yeah, I wonder if it's like they like you said, they're sensitized to it, but they don't continue to have ongoing inflammation. The lymphadenopathy just kind of, they get the granulomas and they just kind of hang out and don't progress.
Yeah. So, but I mean, there must, sarcoid. I've never seen sarcoid last for 20 years. Have you, Jeff?
Right. No, I mean, if the lymph nodes don't go away, they usually calcify at least.
Yeah.
I haven't seen like non-calcified chunky lymph nodes persist.
Right.
It either goes away or something. Yeah, that's interesting. I didn't realize it wasn't that sensitive. So you're talking about the lymphocyte proliferation test that they do?
Right. I think the sensitivity of those things is at most in the 80s.
Mm-hmm.
Okay. This is the only case I had mobilized for today.
Okay, I have maybe one more I can show just because it's kind of an interest. I'll show one more here. Let's see. All right, so this patient presented, I don't remember exactly what for, but was found to have a rib lesion. This is the right one right here. And you can see it's expansile. It's got a lot of matrix to it. It's kind of a mix of what looks like maybe fat, calcium, soft tissue. It expands out the cortex, but it doesn't seem to, there's a couple defects, but it doesn't have, it's not a permeative lesion and there's not a periosteal reaction with it. I don't think they had a cancer history. It's not the most typical looking for a plasmacytoma or a renal cell or thyroid met, and that it's not that aggressive looking. It could be a chondrosarcoma or other matrix forming tumor. So it got resected, and this is the specimen here. They've started putting our gross path in packs, which is kind of cool, but you can see here's the expansile lesion, and you can see some cartilage, a lot of cartilage associated with it, and there's some cauterized muscle and blood and some other fat around it there, but it's a well circumscribed lesion. They were able to get it with clean margins. And this is a chondromyxoid fibroma. So it's a benign type of cartilaginous tumor, which would fit, and it kind of fits with the imaging findings of it. But we don't see a lot of chest wall lesions. I mean, we see mets from renal cells and things like that, but we don't see a lot of primary ones. And most of the ones we see are chondrosarcomas. So this is just like for some of the people early in their training, when we describe bone lesions, we talk about whether there's matrix or not, whether it's expansile. We talk about if it has a periosteal reaction, if there's zone of transition. So this has a lot of non-aggressive features, but many chondrosarcomas can, of course, be low grade and have non-aggressive features. So without tissue, you can't always be certain, but given its size, and I presume the patient probably had some symptoms from its tugging on the muscles and such, ended up being a benign lesion. So one I'd not seen before, but it explains the chondro being, of course, there is some matrix in there. So just another little benign tumor there. And that is all. All right, well, we'll have a short meeting today. Thanks, David, and hopefully more people will be back next week.
Very good.
All right, take care.
Thanks.
Yep,
Bye-bye.
bye.